Hello everybody on Facebook, and thank you for joining us for our TIF Talk. I know it's not Tuesday, it is Wednesday, but we are here at a very special event. We are at SAGES annual meeting in Las Vegas. It's their 2021 annual meeting, and SAGES stands for, I'll let you guys say what SAGES stands for.
Society of American Gastrointestinal Surgeons.
Yep. Endoscopic
surgeons.
Endoscopic.
Yeah, forgot the E.
Yeah.
So we're here in Las Vegas with two of our special guests, Dr. Alfred Johnson, who you may have seen before if you've watched our TIF Talks, and also Dr. Eide. In addition to them, we have Courtney Chance, who's here with Endogastric Solutions as well. And my name is Andrea Millers. If you watch our TIF Talks, you would know who I am. So before we start, I do want to introduce our two guests, and we are very happy to have you here. I know you took some time out of your day at being at the conference to do this TIF Talk live with us. Dr. Alfred Johnson is a board-certified and general surgeon specializing in the treatment of acid reflux and gastroesophageal reflux disease, otherwise known as GERD, and related interventional anti-reflux surgery, including the TIF procedure, as well as advanced laparoscopic surgery, hiatal hernia repair, and minimally invasive digestive health surgeries. He is in Merced, California, or I should say practices in Merced, California, at Merced Medical Center, which is part of Dignity Health. Welcome, and thank you for being here with us.
Welcome.
Thank you. We also have Dr. Eide. If you've watched our TIF Talks, you've seen him a couple of times as well. A few times. He is a board-certified general surgeon at Matagorda Medical Group, an affiliate of Matagorda Regional Medical Center in Bay City, Texas. Yep. And so we had a TIF Talk with him just a couple of weeks ago about clinical data and some of the papers.
Yeah, clinical outcomes. Yeah.
Clinical outcomes, yes. So if you are watching live, we encourage you to ask questions for our physicians today. All you need to do is type them in the comment section, and Courtney's actually going to read through the questions, or if you want to say hi to the doctors or tell us a story of what's happening with you, or if you're about to get the TIF procedure, let us know. So let's go ahead and get started. We're here to talk about GERD and TIF. So I'm going to let you guys kind of explain what is GERD, and what kind of symptoms would patients feel, or what would they be suffering from if they were experiencing GERD? Dr. Johnson, you can go first.
Well, GERD stands for gastroesophageal reflux disease, and it basically means that you have pathologic flow of contents of your stomach coming back upward into your esophagus, and this can cause any number of symptoms related to the burning sensation you get from the acid irritating the esophagus, chest pain, shortness of breath, regurgitation, meaning that you feel the contents of things in your stomach flowing back up toward your neck. In some patients it gets bad enough that they feel that they're choking. But there's a whole wide range of symptoms that are related to GERD.
Yeah, thank you. Anything else you want to add, Dr. Eide, in regards to the actual disease state?
Yeah, I mean, sometimes people will have trouble swallowing. They'll develop some scar tissue in the esophagus. A lot of people will have what we call atypical symptoms, where they have cough, clearing of the throat, recurrent sinus infections. That's kind of an also disease. Besides the typical things, we have these symptoms that are sometimes caused because it's irritating all of the things in the upper airway.
Yeah, and we get a lot of comments or questions about LPR. Can you maybe discuss what that is and how does that relate to GERD?
Yeah, so LPR stands for laryngeo-pharyngeal reflux. And it is when the reflux, like regurgitation, comes up to the mouth. If you're awake, you know, you taste it in the mouth. But it's irritating, it spills over into the trachea, irritates the trachea, you get a chronic cough, you're always clearing the throat. Like we said, sinus infections, ear infections are common. Hoarseness can be a significant problem. And the issue with LPR, what we call atypical symptoms, is there are lots of things that can cause a cough, right? There's lots of things
Sure.
that cause you to clear your throat. Could be allergies, could be dust, could be smoke in the room, whatever, right?
Right, right.
So the difficulty is there's no test that exactly says that this cough is coming from reflux. It's an associated symptom. So what we have to do is we have to prove there's real typical reflux first, and then there's an association with it. And so some 80% of the time, it will be associated, and when you treat the reflux, you improve those symptoms. But they may not completely go away because, again, there are other things that could cause
Sure.
cough, right?
Right, right.
And so we look at atypical symptoms as something that we try to treat, but it's a lot more variable in terms of outcomes than treating typical reflux.
Sure. Are you finding the same thing, Dr. Johnson, in your practice?
Yes, and many times, at least with the physicians that are more familiar with this, such as ear, nose, and throat surgeons, they're very familiar with LPR. And so I've had some of them actually will go through the trouble of getting a barium esophagram prior to referring a patient, because many times, even though the patient has these atypical symptoms, when they do the esophagram, they can actually see the reflux happening on the study.
Wow, okay. And I often hear sometimes dentists also will see kind of erosion on the back of their teeth. Do you guys see that as well in patients that you treat?
Well, not necessarily see it, but you know, the patient will know that their dentist has told them that.
Okay.
Yeah.
Okay. Do you get referrals from dentists sometimes, by chance?
Oh, yeah.
Yeah, you do. Okay. Okay. So, what? Let's move on and talk about managing GERD. Right. I know you both are general surgeons, so not GIs, but we'll talk a little bit more about the role of a GI versus general surgeon and CTIF, concomitant TIF. But initially, what do you recommend for patients to do if they are suffering from symptoms of GERD? You know, lifestyle modifications, obviously medical therapy with taking PPIs or whatnot. Do you want to talk a little bit about that?
Sure. So at the present time, we don't have any particular medication that specifically addresses the underlying problem of GERD, which is dysfunction of the gastroesophageal junction, or flap valve, as we call it, which is in association with the LES, or the lower esophageal sphincter. So the only medicines that we're using are medicines to alleviate symptoms. And first thing you want to alleviate is the acid in the stomach. So you can start with simple things like antacid, Tums, Rolaids, Maalox. And then I've even had patients come to me that mix baking soda and water in order to get relief.
I've heard that.
And then you go up to the next class of drugs, which will reduce acid secretion in the stomach, which will be the H2 blockers. So things like Tagamet, Zantac, Pepcid would be the next class of drugs. And then the most potent drug to reduce acid secretion would be the proton pump inhibitors. And they will really restrict the amount of acid being produced, and that would be the things like Prilosec, Nexium, Dexilant. But as you know, I'm sure you will hear through this discussion that there are other side effects associated with taking these very strong proton pump inhibitors over long periods of time when you're altering the normal physiology of the GI tract.
Sure. Yeah, thank you. Anything else to add, Dr. Eide?
Yeah, and so like was described, this is like a progression of treatment where you're sort of treating yourself, and then you're seeing a physician, and then you're getting on these stronger drugs, and that's about, you know, if you look at the time period to be treated, you know, you're doing 6 to 8 weeks of antacid, 6 to 8 weeks of H2 antagonists, 6 to 8 weeks of PPIs, and not getting a result, that in total is about a 6-month period of time. So if you've gone 6 months and you haven't been able to control those symptoms, or you can't get off of the medicines without getting the symptoms back, that's the time to go to a physician and have an evaluation.
That's a really good point. And we get lots of these questions. When do I need to go see a physician, or when do I make that decision to take the next step? And also, you know, do I go to my PCP? Do I go to my GI? Do I go see a general surgeon? So because you both are general surgeons, do patients come directly to you for GERD treatment options, or are they generally referred to you from a PCP or a GI, or is it both?
It's both.
Okay.
Yeah, it's all three, right? So
Okay.
generally, you'll be working with your family physician, your primary care doctor,
Sure.
and you know, they'll kind of guide you through those initial 6 months of transition. And then a lot of times the family doctor will refer to a gastroenterologist, which will do some initial studies that will confirm, yeah, this is reflux disease, and maybe double the medications for a period of time. But then at some point, if that's not controlling the symptoms, or if you can't get off the medications, then they're going to send you to somebody who can do an intervention. And that might be a gastroenterologist, because gastroenterologists do transoral fundoplications, incisionless fundoplication. And surgeons do as well. I've done endoscopy my entire career. A lot of surgeons do, and a lot of surgeons don't. Right. So they may work hand in hand with the gastroenterologist if it comes to the time to provide an intervention.
Yeah, good point. So I wanted, since you discussed endoscopy, I kind of want to move into kind of the diagnostic testing that you guys will do to determine, you know, am I a candidate for the TIF procedure if a patient decides, yes, it's time for me to do something more than just take PPIs. So can you talk a little bit about the diagnostic workup that you do? I'll let you go first, Dr. Johnson, and then I don't know if you guys have similar
yeah, we haven't talked about it.
I know, I didn't even think
what do you
about
do?
that. Yeah. So, Dr. Johnson, I'll let you go first.
Well, I think the number one thing that
We're going to have you.
Oh,
Your mic's off, first of all.
Oh.
Yep, sorry. We're just,
okay.
we want to make sure you can hear him.
I think the number one thing you want to make sure of when you're going to do any surgical intervention for a patient that has reflux is that they actually have reflux. But that can be determined in several different ways. One way is a symptomatic patient that you can visualize reflux on a barium esophagram. Mm-hmm. You can do an upper endoscopy and diagnose the patient with esophagitis just by both visually and on biopsy. And when you do an endoscopy, you're also able to evaluate the presence of a hiatal hernia, which many times is either downplayed or just not recognized on a barium esophagram. And then there are other diagnostic studies that can be done, especially with patients who have a little bit more, they may have a more difficult history or the symptoms are not as severe. And then, you know, the 24-hour pH is very important for this particular population, which is done with the Bravo probe. And then finally there's esophageal manometry, which is done to evaluate the esophagus for any other motility disorders or problems of the muscular function of the esophagus. But, you know, I've been doing fundoplications for a long time, and initially we were doing manometry to determine that when you did a Nissen, the patient had adequate motility to open that valve.
Okay.
And, you know, this was, you know, 20 years ago, but as the treatment of surgical treatment of reflux has evolved, we are no longer doing procedures that can't open a valve. So the main thing you have to do is to prove that they don't have something like achalasia or some other motility disorder in order to do an intervention.
Sure. Yeah, that's a good point.
Yeah.
I think your mic's working.
Yeah, my mic's working.
Just you, Dr. Johnson.
Yeah.
We're going to have to hold this.
Yeah. So, yeah, the workup to look at reflux disease exactly as you describe, endoscopy, a pH study, some sort of manometry. So there's a newer type of manometry called EndoFlip that I use. It's nice because we can do all the work at one setting. But then there are 2 additional tests I usually get. One is a HIDA scan, which is a scan that looks at gallbladder function, make sure it's functioning well.
Okay.
Because it's one of the disease processes that can mimic symptoms of reflux. And so exactly as you said, you want to make sure that you're operating on reflux and not something else. And then the other is a gastric emptying study, because a lot of 20% of patients statistically are going to have slow gastric emptying, and that can give them some symptoms that they may feel like are still reflux related, but they're not. It's a different disease process, and you may have to address that after a reflux procedure, but you need to know beforehand, not after. Yeah.
Gotcha. Okay, we really appreciate that. Before we go on, I'm going to go hand it to you, Courtney, and see if we have any questions.
Yeah, well, it's great timing because now we've talked about some of the tests that can be done, but we have Chastity here who said that she's had the test done and she's been referred to a doctor, and she just wants to know what kinds of questions should she be asking when she goes to her appointment.
Dr. Johnson, you first. Sorry, you got the mic.
Well, I guess I'm a little bit at a disadvantage because I don't know what procedure the doctor was offering her.
That's a good point.
But what she's going to want to know is, you know, what type of surgery is it? Is it a minimally invasive surgery? Are they planning laparoscopic surgery, robotic surgery? Is she going to have a hiatal hernia repaired? Is she going to be kept in the hospital overnight? You know, how long will she have dietary modification after she's had surgery? When would she go back to work?
Yeah.
Those are all.
Yeah. Very good questions. Yeah. Anything else to add, Dr. Eide?
Well, and the surgeon or gastroenterologist will always talk about risks and benefits.
Yeah.
You know, we assume the benefit is, you know, get rid of the reflux, but what are the risks, and then what are the alternative procedures, and why would you pick one procedure over the other? And it's usually a balance between those two things. Is, yeah, maybe this works better, but it's not as risky. Maybe this works better, but it's more risky, right?
Right.
And to get some sort of understanding of what those risks are, I think is important. And then also, I generally keep my patients on a post-operative diet to kind of, I tell my patients it's rehabbing the esophagus, getting it to swallow with better strength and better coordination.
Right.
Because, you know, it's been abnormal for a period of time. You've had that reflux do damage to the wall of the esophagus.
Sure.
We need to get it back into shape, and so there will be usually a prescribed post-operative diet, and you should have some sort of understanding what that's going to be.
Yeah, it's good. All right.
Well, there's a lot of talk about cough, and we kind of talked about this a little earlier, but given COVID and the times that we're in, people are wondering if they're having a cough, how can they tell if it's, obviously they can take a COVID test, but how can they tell if it's more and that they should be pursuing some kind of treatment or consulting with a physician?
So you kind of have to know the timing of the cough. Is she having is that person having a cough when they exercise, when they exert themselves? Are they having a cough after a large meal? Are they having a cough when they finally go to a recumbent position and may not realize that they're having some type of LPR or silent reflux? But it really depends on the context of the cough, I think, in terms of what type of evaluation would be done when the symptoms start to occur.
Also, if it's happening frequently, right? If it's
right, if it's
consistent,
consistent, a new finding, you know, versus something that's been happening every once in a while for months or years.
Yeah, yeah. Okay. Anything else to add?
Well, and the other thing is, you know, how do you know if it's related to reflux? Well, do you have the typical reflux symptoms? So if you have heartburn, and then, by the way, you also have a cough, those are more likely to be related than if you just have a cough, never have heartburn. It's unlikely to be reflux induced.
Yeah, good point. More questions?
Yeah.
Okay. There's a lot of questions popping up, so
Okay.
that's good.
So Jeremy says that he's been off and on PPIs for and H2 blockers for several years, and he's currently controlling his GERD symptoms, his previous symptoms, with a paleo diet. He's asking if that's something that he might consider or could be at risk for getting diagnosed with in the future, and how his lifestyle modifications can play into preventing a GERD diagnosis at some point down the line.
Well, he has a GERD diagnosis, right? And so the question is, how do you keep GERD under control? And weight loss is an excellent way to do it. Watching your diet. Those are all the primary things that we recommend, right?
Sure.
Is you can elevate the head of the bed. Kind of the break point that people get to is, you know, if it requires medications to control the symptoms, do you want to be on those medications for the rest of your life? And what are the side effects of those medications? So you talked about, you know, those are one of the things that we want to review. That's when you have to make the decision about, well, am I going to get it evaluated to see if there's anything else that can be done?
Yeah. Anything else to add, Dr. Johnson?
No, I think
That's right on. Okay. More questions, Courtney? All right.
There's a lot of questions.
Lots of questions.
All right, so we talked about cough, but what are some other atypical symptoms related to GERD that people might not be aware of?
Well, one could be chest pain. Chest pain is more of an atypical, not the standard symptom of reflux. Some patients may be familiar with going to the emergency room thinking they're having a heart attack.
That's common.
They do the initial diagnostic workup and essentially exclude the heart being the issue, and they give them what's called a GI cocktail, and that resolves the symptoms. So that's, you know, that's a potential atypical type of scenario where, you know, it's not the usual heartburn,
Yeah.
but, you know, ultimately it turns out to be GERD.
Yeah. So interestingly enough, I have a story. I actually have GERD. Well, I haven't had my endoscopy yet. I haven't been, but my general practitioner put me on Prilosec. But prior to that, I kept losing my voice, and it would get hoarse. And so that kept happening, and my voice has actually changed. And then I got on my PPIs, and all of a sudden my voice kind of came back to my normal-ish tone. I mean, I have a deep voice already, but that's another symptom, right? The voice loss. Or
you bring up a good point, is that if you're having symptoms and you get put on PPIs and the symptoms get better, that is one of the litmus tests they use to diagnose reflux disease before you even get endoscopy.
Yeah, Dr. Eide says I'm a bad patient because I need to go get my endoscopy. So that'll be on the next TIF Talk, one day.
And then talking about atypical symptoms, something that drives my sister crazy is her husband is always
oh yeah,
like constantly, right? And she's like, you gotta go get that fixed. And he's come in and maybe we'll get it fixed, but like for 10, 15 years, he's been clearing his throat about every 5 seconds. It drives her nuts.
I've heard that too, and then they stop and they're like, why is it so quiet? They just realize that white noise of clearing your throat all the time. So,
So another common theme in the questions that are coming in are that people's doctors are having them stay on their medication, but they're really not getting any better. Their symptoms aren't subsiding. In fact, they're getting worse. What can they do?
See you guys.
Well, they need to keep complaining. Number one, if that they need their physician to be responsive to their complaint. And if you've been put on a particular treatment regimen and it's not working, then you need to keep probing until you can find some relief.
Yeah. There's no need to suffer, right?
Yeah, and there's a background to that. In the past, there were older fundoplications, older procedures for reflux that had a lot of side effects. And there was a period of time in which they started doing those procedures. the medical community in general realized that were a lot of side effects, and so they quit referring patients for a procedure to fix that. And that's right around the time that, you know, the proton pump inhibitors became popular. And so we're talking 30 years ago.
Right.
And so initially they thought, well, these are very safe, there's no side effects. Since we've learned that there are things that can occur when you're on a medication for 20, 30 years, and although TIF is not new, there are a lot of physicians that still don't know about it, so they don't realize that there is an alternative that doesn't have the side effects of older procedures.
Right.
And so the hesitation to do anything is based on the previous 30 years of experience with an older fundoplication that maybe gave a lot of side effects, and not so much knowledge of a new procedure that you can do. So one of the things you can do is go to your primary care doctor and say, they love to hear this, I've been reading on the internet and say
Saw something on Facebook.
There's this procedure and would I be a candidate for it? And it's a very, you know, open way to have a discussion with your physician about the alternatives to medication.
I think that's okay. I think you need to be, and I think one of the things and reasons why we have these TIF talks is because we need to educate patients. I'm not saying TIF is for everybody, but you should be an advocate for yourself and do the research, right? And learn about what other treatment options are out there to make you feel better if you're not feeling better in the treatment plan that you're in.
There's always alternative treatments. There's never one treatment for anything.
Exactly.
And so if your physician is not aware of this particular alternative, it's okay to go to them and talk to them about it.
Yeah, yeah. Did you have another question, Courtney? We got another question. All right.
So Michael asked a question that tied into basically everything you just said, but in addition to his doctor being unaware of what TIF is, that doctor seems to think that a Nissen or another alternative procedure is the best solution. And so he wants to know the best way to find other options, right? And part of it is, it sounds like there's some issues with finding insurance coverage. So how would you suggest that he could navigate that?
Dr. Johnson's kind of answer.
I think one of the ways to navigate that is to at least go through the process of having the evaluation. So his primary care physician should be able to refer him at least to a gastroenterologist who can do that workup. And, you know, they can set up the barium esophagram, they can do the Bravo pH study, they can set up, they can obtain most likely a manometry study for that patient.
Sure.
And then he's going to have some additional information about what things might be out there available. And if he does have a substantial hiatal hernia, then the options are not going to be difficult in terms of finding insurance coverage. It gets a little bit more difficult when you don't have a hiatal hernia that can be described in a report to the payer ultimately.
Mm. So. Okay. Dr. Eide?
Yeah, so that's a good point, is that you know, the treatment of reflux disease has been around for a long time. Surgical procedures really date from the 1950s. So there generally is insurance coverage for procedures. The question is, you know, like you were talking about, what diagnosis is being used and what other things that go into it. Because we generally think of reflux as being a failure of more than one structure and requiring more than one fix, right?
Right.
And so hiatal hernia repair is wrapped into fundoplication in the way this is coded. And so that's why that has been something that insurance payers have covered for a long, long time. And likely if you have a hiatal hernia, then you fall into that category.
Yeah, let's talk about that, surgical treatment options, right? Can you please describe the different surgical options? And also, you kind of touched on the hiatal hernia part that's combined with the TIF procedure. Can you maybe describe what's out there, right? we know that there's a standard Nissen procedure, laparoscopic Nissen, the TIF procedure, other procedures. Let's first talk about what treatment options are out there outside of the medical therapy and lifestyle modifications and whatnot first, and then we can maybe just, you guys can describe how the hiatal hernia needs to get fixed and how surgeons come into the picture. So I'll let you talk about the different options right now first.
Well, the primary option, which has been around for a long time, is the laparoscopic Nissen fundoplication. That is what we call a 360-degree wrap, meaning it's like having a portion of your stomach completely encircling your esophagus in order to augment your reflux valve to prevent reflux. But what we have found over the years of doing this is that there are other adverse side effects of having a Nissen fundoplication, of having anything wrapped completely around your esophagus. One of those things being that you cannot vomit after that's done.
Right.
And you can get things such as gas bloat. So it's kind of like all of a sudden where you had a defective valve between your esophagus and stomach, now all of a sudden it's very competent. And because of that, things aren't coming up, so they're going to go the other way. And therefore you're going to get, pretty significant gas bloat as a result of that. And the other issue that people have with fundoplication, with this type of fundoplication anyway, is trouble swallowing many times. And you have to alter what you're eating and when you're eating and the amount you're eating. And finally, if you have a fundoplication and you subsequently get sick and end up in the hospital, you have to notify the medical staff at that facility that you had a fundoplication, because you're going to need a nasogastric tube, most likely, to treat something if you have some other abdominal condition.
Good point. Right. That's a really good point.
Right.
Yeah.
So then, those are fundoplications. There are two really other classes of treatment. One I generally put into the realm of bulking, is they make the end of the esophagus bulkier. And there's been procedures where they actually did injections. Those aren't available anymore, but there is a procedure where they can use radio frequency to cause some scarring and bulk up. So bulking is one way to do it.
Okay.
The next way is kind of what we call stenosis. Back in the day, they used to put a little silastic ring around the esophagus to kind of keep it narrow so that controlled the reflux. But then they had problems with it, and that went away. But they have a newer procedure where they put magnets around, and they hold things closed, and then the magnets are not strong enough to keep you from staying close if you want to swallow something down.
Sure.
So that procedure is available, but again, if you have a hiatal hernia, you need that fixed at the same time.
Okay.
And then really there's the third class is fundoplication.
Sure.
And what that is, as you've described, putting a cuff, if you will, of stomach around the end of the esophagus. And there are full fundoplications. Nissen is called a full fundoplication, 360 degrees. And there are partial fundoplications, and there's lots of different ones. There's Hill, Toupee, Door,
yeah.
blah, blah, blah. Right, so there's lots of those partial fundoplications, and they're done laparoscopically. And then TIF is a fundoplication. It's transoral through the mouth, incisionless. You're not using the incisions to do the fundoplication. And then fundoplication is the F in TIF, right?
Right.
And they all work through a very similar mechanism, that cuff around the esophagus, but they don't all have the same side effects. And so one of the reasons in particular that I offer TIF to my patients over a Nissen, for example, because you could do any of those fundoplications laparoscopically,
Sure.
is that it doesn't produce the bloat, the dysphagia, the inability to vomit. Those sorts of problems are throughout the articles that have been published on TIF. Those are not produced or occur as a side effect after TIF.
Right.
And so That's the way I look at it. Is there's kind of three classifications of procedural
treatment options.
Treatments, right?
Yeah,
right. Thank you.
Yeah.
And but by far the most common treatment option has been fundoplication, and the reason we use TIF as the fundoplication is because we're avoiding the side effects of the other fundoplications.
Yeah, and one thing I think maybe our viewers don't know about, or we never really talk about it. We always say TIF is incisionless, right? And it's going transorally, but you're actually building the valve internally versus externally.
Right.
And we never really talk about that. Do you guys mind discussing that a little bit?
Sure. So what I try to describe.
Just to make sure they can hear you.
Yeah.
Sorry.
When I know that a patient has the condition, I may have already studied them. I already know that they have a hiatal hernia. But I try to describe to them that the integrity of the gastroesophageal junction and the flap valve is lost over time, and that's when people are really having the progression of their symptoms. And one of the things that we'll find is when that conformation changes at the angle of His, the angle of His is that portion where the stomach is kind of coming up adjacent to the esophagus. And this whole area is normally resting below the diaphragm. But over time, that angle of His starts to come down. If my hand is the stomach that's next to the esophagus, it starts to slide down. And as you lose that conformation, the end of your esophagus is becoming more like a funnel than a flask. And what we were doing with the TIF procedure is essentially pulling that angle back down. We pull the angle down so that that stomach can come back up against the esophagus. And that's what restores the flap valve that allows patients to get relief from pathologic reflux, but they can still do things like vomit if they need to, and they don't have the gas bloat.
Sure.
Yeah, you know, when we talk about fundoplication, I describe it as a cuff, and you can pull a cuff around from the outside, which is what you're doing laparoscopically when you go in through incisions. Now, we use the incision still to do the hiatal hernia repair.
Sure.
That's one part of the procedure. The fundoplication is a second part of the procedure. So in my mind, I always separate those two. So once you have the hiatal repair, it's easy to hitch the stomach up and then suture it to the outside of the esophagus, right? That's one way to do it.
Sure.
TIF, because we go in through the mouth, and from the inside we fold the fundus or that part of the stomach up to the esophagus and then suture it in place. That's why we say it's transoral and incisionless, because we're not using the incision approach to do that part of the procedure, the fundoplication part of the procedure.
Right.
And I don't think that they really know why bloat and dysphagia and those sort of things really happen after a Nissen. But we know that they don't happen after a TIF, and that's the important part.
Right. Patient satisfaction, right?
Yes.
Yeah. Do we have any more questions, Courtney?
We do.
All right, let's get to some more questions.
So there are several questions that have come in that are really just more on the procedure itself.
Yep.
What, as a patient, can they expect before and after the operation?
Well, that again depends on, are we repairing a hiatal hernia in addition to doing a TIF,
That's a good point.
or are we just doing a TIF? The symptoms that a patient would have before surgery will essentially be, if not gone, almost significantly reduced, really in the first 24 to 48 hours after. The patients that I do the procedure on, I actually take them off of the PPIs immediately.
Right after?
Right after surgery. So they don't even take them after.
Wow.
Now, there have been some patients down the road that take them intermittently, but nothing like before.
Yeah.
And still are extremely happy that they had the procedure done.
Okay. What about you, Dr. Eide?
Yeah, so the first thing everybody wants to know is it going to hurt, right?
Yeah.
And I tell them, you're going to be sore. 3 spots, right? You're going to be sore in the throat because this device goes down the throat and it's plastic and it's going to be sore.
Sure.
Gets better, ice chips, popsicles, chloroseptic spray,
Yeah.
all those sorts of things. They're also going to have some soreness to the chest because, you know, we're really operating right in that area, especially if we do a hiatal repair, hiatal hernia repair. You know, you're pulling the diaphragm back together. You certainly feel that. And even with TIF alone, you're going to get some irritation of the diaphragm, and you feel that as shoulder discomfort, kind of a, people describe it as a burning sensation or kind of an irritation of the shoulder. And the reason is the nerve that goes to the diaphragm comes from the neck level, from the 3rd, 4th, and 5th vertebrae. And so the rest of that innervation's at the shoulder, even though this nerve goes all the way down to the diaphragm, and so you feel it in the shoulder.
Sure.
And then, you know, typically it takes about 3 days for those things to get better. If you look at pain studies, it's about 3 days.
Sure.
And then I put them on the post-operative diet. And
Do you keep them on PPIs as well, or
I keep them on a PPI for 2 weeks.
Okay.
And then same thing, come off of PPIs. It's rare for them to go back on PPIs. Sometimes people will take those medications for other reasons. So there are people that still use the medications, but their reflux is controlled and they're not waking up in the middle of the night and they're not coughing, having coughing fits, and clearing of the throat gets better. Takes some time for hoarseness and clearing of the throat to get better. But their heartburn and regurgitation in particular, as soon as the anatomy is in place, that basically stops.
Yeah. So we talk about the hiatal hernia a lot, right?
Yes.
And repairing that as well as doing the TIF procedure. In your practice, both of you can speak to this. Do you find that most patients that do have GERD actually have hiatal hernia that needs to be repaired?
Yes, I would say that the majority of patients that have the condition, especially if it's been over years, are going to have a hiatal hernia that needs to be fixed.
Yeah. So in your practice, are you generally fixing both all the time for the most part? Yeah.
So the majority of the time I'm doing
Both.
Both the hiatal hernia repair and the TIF procedure at the same time.
Okay. And then for you, Dr. Eide?
Yeah, so the answer to that is yes, but you also have to realize that we're surgeons, right?
Well, yes,
so people don't get to us until they've been through all the other alternatives, and we're sort of like the last stop on the, you know, the train ride. So you may go to your gastroenterologist and they don't feel like you have a hiatal hernia, and then they could do a straight TIF. There's lots of patients that are like that.
Sure.
But of course, by the time you get to a general surgeon, you probably do have a hiatal hernia. That's one of the reasons why they send you to a general surgeon, because they know you'll need that hiatal hernia repair. So it's a little bit of a bias, if you will,
to
the question, because you're talking about two surgeons.
No, and that's why I wanted to bring it up. So, you know, obviously you guys do both, right? You guys can do the hiatal hernia repair and the TIF procedure. And we also know that gastroenterologists can also do the TIF procedure. And generally when they find patients that have to have a repair, they partner with a surgeon.
Absolutely.
So there'll be different scenarios where that can happen, right? If you just need a straight TIF, you don't have to have a hiatal repair, then they can do a gastroenterologist, or you guys can do a straight TIF. If they do need the hiatal hernia repair, you can go to a surgeon that can do both, and or go to a team of GI and surgeon. Surgeon fixes the hiatal hernia, and then the GI will repair, do the TIF procedure, sorry. Yeah, so I just want to make sure that that was clear. Did you have something to add to that?
And I think it's important for folks to understand that GERD is a spectrum of disease. I mean, it starts out when maybe it's just primarily a dysfunction of the flap valve and not really associated with a hiatal hernia. But as you get further and further in the disease process, there's more and more loss of integrity of all those structures holding the normal position of the flap valve under the diaphragm, and your hiatal hernia gets larger and larger. And by the time you get to the end of that disease process, you may have a large hiatal hernia. Maybe you don't have a lot of symptoms, but if you are studied and you had an endoscopy that shows that you have changes in your esophagus, there are patients that have Barrett's esophagus, which is kind of the end stage of the reflux process, that don't have a lot of typical heartburn symptoms, but they may have a lot of regurgitation.
Right, right.
And Barrett's is important because that is almost like a adaptation of the body to the fact that you are refluxing too much.
Right.
So
that's scary.
The acid is not supposed to be in your esophagus on a frequent basis. So when you start to have damage to the lining of the esophagus, the body is essentially telling some of those cells, we need some protection to this acid. We're going to turn these cells into cells that are more like the stomach, because the stomach is used to seeing acid.
Right.
But as you get these abnormal cells in your esophagus, because of the anatomy, these cells tend to undergo changes over time that predispose them to developing cancer of the esophagus.
Yeah.
So that's why it's important to understand where you are in the disease process. If you've had GERD for a long time, symptoms for a long time, you should be evaluated.
Yeah, I'm so glad you brought that up, because the next question I was going to ask you, what happens to those if they do not do anything? What's the worst case scenario? And you had just mentioned Barrett's, but then obviously esophageal cancer, right? I mean, it's what, the second highest cancer that's growing? It's like 600% or so.
Well, most cancers in the United States are being adequately treated and they're fairly stable. Esophageal cancer is one of the few cancers in the United States that's increasing in incidence, and it's not like a little bit, it's like 600% increase in the last 30 years. And it may have to do with the fact that people are now able to get these medications over the counter, so they're able to take them and kind of feel. Nobody wants to go see a doctor, right? So they don't go see the doctor, and before you know it, it's 20 years down the line, you've had this acid damaging the esophagus all this time until, like you say, it makes these cellular changes, and then those cellular changes can predispose you to develop esophageal cancer. It's not a direct relationship, but it increases the risk.
Right.
So much so that if you do have Barrett's, you need an endoscopy about every 3 years to keep an eye on it.
Yeah, yeah. Well, yeah, thank you for bringing that up. It's a very important part of everything. We're getting close to the top of the hour, but before we conclude, I want to just double check with you, Courtney. Do we have any other questions?
We have a couple quick questions.
Okay,
if we have
sure.
time.
Yeah? You guys have time?
We're here.
Well, I'm glad you covered Barrett's, because that was something that came up. But the next it's two topics, is what's the recovery like? And as part of recovery, how long until you can get back to regular exercise, back to work? And then the second part is really more around durability. And after the TIF procedure, whether you have a hiatal hernia repair or not, how long can you expect to have relief?
Those aren't quick questions, Courtney.
I'm sorry.
I'm just kidding. Very important questions,
They're very
actually.
important.
Well, in terms of the laparoscopic hiatal hernia repair combined with TIF, I typically will keep those patients off of work for about 2 weeks. But there are many people who have, jobs where they don't exert themselves. They're sitting at a desk. And it's not unusual for me to have a patient that has a surgery on Friday and are back to work the next week.
With both the combined?
Yes,
Okay.
the combined.
Okay.
But it kind of depends on the situation they're in. If you
Their
have
job.
someone that does a lot of heavy labor, we'll probably keep them off a little bit longer, just so
Sure.
they're not putting a lot of stress in their abdomen. But and then for patients that have TIF alone, it's mainly about getting them that they've adapted to dietary changes, which are going to be required temporarily until they can eat.
Yeah.
So to the extent that they can do that at work, they don't really have much of a restriction in terms of when they go back to work.
That makes sense. Yeah, absolutely. What about, do you want to speak to durability? Dr. Eide is like, I do that.
Durability, again, we're talking about two procedures a lot of times that are together. And in terms of looking at a TIF alone, there are 10-year studies showing that durability is sustained over that 10 years. So you may have some initial failures, a percentage, maybe 5%, 10%, but then once you get past 6 months, there are studies that are very clear that that's pretty stable for up to 10 years, right? And that's as long as we have studies. We have a very good 5-year study that was done prospectively, multi-center, that shows very stable after the first 6 months. Then there's the hiatal hernia repair, and that's a whole nother story, because I think that surgeons that have previously done, like Nissens, do hiatal repair with the Nissen. The real weakness of that procedure is the hiatal repair.
Right.
And we know that the recurrence rates are higher for hiatal hernias, maybe 15%. And so in the long term, what is it that you can do to protect yourself, right? We used this example last time, right? It's sort of like everybody wants everything to last forever, but that's not the way the world is. It's like, putting new tires on your car. Is if you want to keep those tires for a long time and not have to buy them again, then don't peel out at the stop sign every time you take off, right? You're not going to wear out the tires as fast.
Right.
Same thing, a hiatal repair, the thing, at least in my practice, it seems to associate with that is heavy lifting.
Right.
And so, for instance, I will put a restriction of 15 pounds for 2 weeks and then 30 pounds until you're 8 weeks out. Then after that, we don't really have data. We don't know what it is or how much. I generally say, listen, if you can avoid lifting more than 50 pounds, then don't, and likely that's sort of like not peeling out at the stop sign. Likely you're going to have a more durable repair. But I mean, some people, they're off-time activity. Like, I'm in a rural area, right? So we have a lot of guys that are lifting bales of hay and putting corn in the feeders. And so that's, heavy work. The bag of feed's at least 50 pounds.
Right.
And those are the people that I see back that have recurrent hiatal hernias, even if the fundoplication is still intact. And they are becoming symptomatic again. Certainly not as bad as they were to begin with, but it's been so good to have no symptoms that immediately, as soon as they start having heartburn 2 or 3 times a week, they're like, oh, check this out, let me know what's going on.
Yeah.
And it seems to be the lifting, the heavy lifting, that triggers that repair to deteriorate, and then they get symptoms back. So in terms of durability, I think that it's very clear to me, at least, that your durability issue is more the hiatal hernia repair than it is the fundoplication, particularly the TIF.
Okay.
And I can just add to that,
yeah.
The hiatal hernia is just like any other hernia. The hernia is essentially a weakness in some part of the abdomen. And to the extent that you can mitigate stresses on that repair, you're going to have a longer lasting repair. So one of the things that increases the risk of hernias developing is visceral fat, gaining weight, smoking. So if you can eliminate smoking and maintain your weight at a stable weight, you're less likely to have a recurrence of the hernia.
That's a good point. Yeah.
And a lot of patients will say that they're not very hungry after the procedure, which is an interesting thing.
Okay.
And they do lose weight. They'll lose 10 or 15 pounds easily. Now, if you watch it, you can maintain that weight loss.
Sure.
If you don't, and you can eat anything you want because you're not having the reflux, you can gain a lot of weight.
Yeah.
So it's a very good point that you don't want to suddenly start eating everything and putting on weight, because it will reduce the effectiveness of the reflux procedure.
Healthy lifestyle, right?
Yeah.
Yeah. Well, again, we can't thank you guys enough for joining us. I know we took some time out of your day here at SAGES, and I know everybody that's watching really appreciates it and has the ability to ask questions straight from you, getting answers straight from the doctors. So if you guys are watching and you are in the Merced, California area, you can go see Dr. Johnson. If you are in kind of the Bay City, Houston, Texas area, you can go see Dr. Eide. But if you're not, you can go to gerdhelp.com. On our website, we do have a physician locator. You can put in your zip code or state, and you can find a physician in your area that is a TIF trained physician. So any last words of advice for those that are suffering from GERD? I feel like you're going to be talking to me, but that's okay. I'll take it.
Yeah, if you have had symptoms and it's been 6 months, go get a workup.
Yeah. Check.
Yep.
And don't take no for an answer.
That's a good one. They're both good,
Right.
but that is a really good
Yes.
point. Because I hear on these boards and the Facebook pages and groups that, oh, my doctor said that TIF's not good, or oh, my doctor said I can get this or that or this or that. And, you know, like I said, be your own advocate, do your research, talk to physicians, talk to your own physician, and find the right team of physicians or family members that you feel good about, and you can make the right decision for you.
There are alternatives to medications.
Yes.
And they work well.
Yeah. Yeah.
So.
Well, perfect. Any last words, Dr. Johnson?
I think we've covered a lot.
We did. Well, thank you again for joining us this evening. We will be back next Tuesday for our TIF Talk Tuesday next week. So please join us then, and thank you for joining. Have a great evening and stay safe. Take care.